Good morning, this is Dr. Dumestre, board certified plastic surgeon, and this is a video that I'm making to share with my own patients who are going through this. So this is my personal approach to mastectomy flap necrosis, and I'm going to be discussing it in the setting of double mastectomy with immediate double deep flap transfer. This is an independent scenario from if you're doing a double mastectomy and an immediate implant reconstruction, or if you've already had implants or expanders placed and you're getting a delayed deep flap. So it's specific to the immediate reconstruction. So mastectomy flap necrosis, what it is, this causes patients a lot of distress and also a lot of confusion in distinguishing between this and deep flap necrosis. So when you have your breast gland, you've got the skin. You've got a thin layer of fat that is not the breast gland. That's what's in pink there. And then you've got your actual breast gland, which is in blue. And then you've got all of the blood flow. So blood flow is key to keeping any living tissue alive. So you can see you've got arteries, veins that are traveling through the breast gland from your chest wall. And then you've got a little bit of blood flow that's coming through the fatty layer that's underneath the skin. Now, what happens in a mastectomy is you are getting that breast gland cored out and you're keeping that fatty layer underneath your skin. So what happens is as all of this breast gland is being removed during the mastectomy, you are losing all of that blood supply and you are now relying, so you can see all of those ends are cut. You don't have any blood flow coming from the chest wall to the breast. You're now just relying on the blood flow that's coming through the skin to feed the nipple and the overlying skin. So when I'm talking about mastectomy flap necrosis, it's death of a portion of that exterior skin envelope. Now, when we do the deep flap, so you've lost the blue breast gland, and this is now an empty envelope. So I'm now bringing up this purple ball is the piece of fat that's taken from the belly and moved up to the chest. And this is basically like a same person transplant. So again, blood flow, you need it to survive. And this blood flow is coming from the microsurgery that we do. So from hooking up an artery and a vein in the chest. So you now have blood supply of this internal filling of the deep flap through a separate artery and vein. Now, this does not communicate with the mastectomy flap initially. It takes time to build connections between this inner tissue and the outer. So initially, there's two forms of necrosis that you may be dealing with. There's a necrosis of the outer skin envelope, which is mastectomy flap necrosis, and then there's necrosis of the inner filling, the deep flap, and that can be just partial necrosis, which is firm areas that you may feel in areas of the flap that don't have as good of blood flow, or it may be total flap loss, which is when you've got a problem with the blood flow here, so you don't have anything flowing to this piece of tissue, and then that dies. So again, separate issue, not what we're talking about today. But very important distinction, because often when people have this mastectomy flap necrosis, they've got some purple, some black discoloration to the skin envelope. They often fear that they are losing their deep flap, the inside of the filling, and that's not what's happening. So what are the risk factors for it? So the risk factors for mastectomy flap necrosis in the setting of deep flap is an immediate reconstruction. So when we do the deep flap on the same day as the mastectomy, you've got an increased risk for death or partial death of that skin envelope because you're losing that blood flow the same day. The second risk factor is large-breasted women. So when you're losing blood flow to a large aspect of your breast, your nipple, and then I'm putting in a heavy piece of fat that's weighing on that, that also increases the risk for the necrosis. Now, how is it managed? So initially, it's just observation. This is not something that can be rushed or that you can deal with in the first couple days after surgery. You need it to declare. And what that means, there's often a central area that is deep purple. And then there's surrounding areas that are just bruising. There's surrounding areas that have poor blood flow, but they're a transition zone. So they have a lot of potential for getting better and healing on their own over those first couple weeks. So when I see you in hospital, I can often identify these areas of risk almost right away within day 1 or day 2. So initially we'll treat it with some paste that enhances blood flow to that area, and then I watch and wait. There is no emergency to going back and taking you back to surgery and removing this dead tissue, because if we go too early before it's shown me what's going to survive, what is for sure dead, then I risk taking out extra skin that you don't actually need removed is going to heal just fine. Because you've got that inner filling that is independent of your outer skin envelope, you've got all of this healthy tissue over underneath. So if you have a little piece of skin that doesn't make it, that dies here, it's not an emergency in the same way that it is with an implant. So then what happens once it's fully declared, so all of the skin around it, there's no more bruising, it's looking nice and healthy, and then you're left with a patch of basically a deep scab, so a fully black scab. At that point now, we can talk about fixing it. If it's just a small little area, this is something that I do right here in the office. I can remove the scab. And if it's just a small area, we just let that heal in by itself. Again, you've got all of that healthy tissue underneath, so you don't have to worry about it being exposed. Open wounds, when they're kept nice and clean, don't actually get infected that often because everything is draining. So in that case, I give you very simple dressing instructions, daily showers, a piece of Xeroform or a little bit of Aquaphor and gauze, and then we keep track of you every week or two and make sure it's sealing in. If it's a slightly bigger area, then it's something that I can sometimes just cut out and close right here in clinic. I put a little bit of local freezing in with a needle, and then you're nice and numb. You barely feel anything, sore for about 45 seconds as I'm doing that, and then you don't feel anything for the rest of the surgery. If it's a larger patch of skin death and you don't have a lot of extra loose skin to close, that's when I'll be taking you back to the operating room, either to do a more extensive reshuffling and closure or to put a skin graft on to that area where you've now got that healthy deep flap exposed. So the skin graft goes there. Then 6 months down the line, you're all healed up. Everything has a lot more looseness to it. You've now grown blood connections between this tissue and here. Everything has a lot better supply. Then I've got lots of flexibility to what I can do. At that point, if there's any poor scarring that's resulted, any poor shape, then I can tighten up the skin envelope. I can cinch things down to really minimize that scar burden. So all that to be said, this is a fairly common scenario in the setting of immediate deep flap reconstruction. It is definitely a stressful thing for patients to go through, but we've got you covered. So we know our management plans, we know our timeline, and we keep in touch to make sure that everything is going as it should be. I'll do a separate video on mastectomy flap necrosis following implant reconstruction, as that is a completely different risk profile. Since you have an implant, a foreign object sitting underneath that breast envelope, you cannot have any open areas. So I treat the mastectomy flap necrosis differently. Hopefully that helps. Leave any questions that you have in the comments so I can continue to make this video better for my own patients and help provide as much peace of mind as possible when you're going through this complication. Have a great day.